Welcome to the JACC podcast. I'm Harlan Krumholz, editor-in-chief of JACC, and this is our issue for October 7th, 2025. What role should artificial intelligence play in scientific writing, and how do we balance clarity with responsibility? Do cardiovascular events really happen in people without risk factors, or is that mostly a myth? Can we safely manage infected device leads with large vegetations without resorting to open surgery? Is CETP inhibition back, cholesterol esterase transfer protein, after years of disappointment? And what can we learn from a trial of upfront combination in diabetes and kidney disease? Plus a deep dive into fibrinolytic therapy across thromboembolic conditions. So let's get started. First, the editor's page, Tools, Not Ghosts. I start this week with an editor's page I wrote called Tools, Not Ghosts. It's about artificial intelligence and scientific writing. We're living through a moment when AI can help anyone improve grammar, tone, and clarity. One of our editors looked at a manuscript recently and said, AI must have written this. What he meant was the writing was unusually clear. That struck me. For too long, poor writing has biased how science is judged. Good science can be obscured by clumsy writing. But now, it seems, when writing is polished, some people suspect it's not authentic. That's not a healthy place for science. For researchers whose first language is in English, or for anyone who struggles with academic conventions, AI can be a lifeline. These tools aren't ghostwriters, they're instruments. I think of them like spell check or reference managers or statistical software. But like any instrument, you need to learn how to use them. And you need validation mechanisms to make sure what comes out is still yours and still accurate. So that's where JACC stands. Authors can use any tools that help them write more clearly. Disclosure isn't necessary, but ownership is. Every author is accountable for every word. Responsibility can't be delegated, not to a colleague, and certainly not to a machine. For me, the principle is simple. Clarity is a strength, not a red flag. And AI, if used responsibly, is a tool that can help science communicate better and fairer. Okay, let's get to the research. First one is about risk factors before CVD. It's a fascinating study from Lee and colleagues using data from more than 9 million people in Korea and nearly 7,000 in the US MESA cohort. The question? How often does cardiovascular disease happen in people without traditional risk factors? We sometimes hear about Smurfless patients. Have you heard that term? Smurfless patients. Those with acute coronary syndromes, but supposedly without standard modifiable risk factors. That's where the Smurf comes from, standard modifiable risk factors. So Smurfless, without no hypertension, no high cholesterol, no diabetes, no smoking. Some have suggested that this group is growing. But here's what Lee and colleagues found. 99% of people had at least one non-optimal risk factor before their first event, whether it was a heart attack, stroke, or heart failure. Almost all had two or more. So the Smurfless phenomenon? Often, it's not that risk factors were absent. It's that they were undiagnosed or present at levels below treatment thresholds, but still harmful. Blood pressure is a perfect example. Risk rises continuously, even starting above 120/80. That's what we've been hearing repetitively. That's what the guidelines are telling us. And in this study, elevated blood pressure was the most common antecedent risk factor. In her editorial, Neha Pagidipati makes the point clearly. Traditional risk factors are still responsible for most cases of CVD worldwide. Managing them, especially blood pressure, remains our best shot at prevention. So the teaching point here is we shouldn't get distracted by the idea that cardiovascular disease is appearing out of nowhere. Almost always, the precursors are there, and we need to detect and treat them earlier. Next, device infections and vegetation debulking. So this is a study about device infections, a growing problem as more patients live longer with cardiac implantable devices. When these devices get infected and vegetation form on leads, it's serious, as we all know. Traditionally, surgery was often recommended if the vegetation was large. This was to avoid embolization during extraction, but surgery carries its own risks. The new multi-center study, led by Malyshev and colleagues, looked at a manual vacuum aspiration device, AlphaVac, used to debulk these vegetations percutaneously before extracting the leads. They reported on 42 patients, and 13 underwent this percutaneous debulking. The results? White blood cell counts fell after the procedure in the debulking group, but rose in the controls, suggesting less bacterial seeding. Hospital stays were shorter, 8 days versus 16. Mortality was 0% in the debulking group compared to 14% in controls. And all of this was done by a single operator without a perfusionist. Now, we need to be careful. The numbers here are small, and it was retrospective. Look, this is really about a proof of concept article. We sometimes publish these in JACC when we think that the knowledge is something that people should know about, and it's an area that's going to be important in the future. In their editorial, Ahmad and Doshi stressed that randomized trial data are needed. They also point out another issue, time to extraction, and this study was often delayed, and we know delay worsens outcomes, so that's another area that could be improved. Overall, this approach looks promising. All the patients in the debulking group who needed reimplantation received leadless pacemakers, lowering future infection risk. That was another thing. We need to think about, what do you do after you've extracted the leads? What do you replace it with? This may be part of the story going forward. Prevention by design, not just better extraction. The teaching point here is that innovation in device extraction is moving fast. Debulking may reduce the dangers of large vegetations, but we need trials. And meanwhile, quicker extraction and broader adoption of leadless systems could be life-saving. Next, CETP inhibition revisited. Let's turn to lipids. Remember torcetrapib, dalcetrapib, evacetrapib? They all failed. These were cholesterol esterase transfer protein inhibitors. Only anacetrapib showed benefit, but it wasn't developed further. So many people assumed that CETP inhibition was a dead end. But along comes obicetrapib. This is a new one. In this pooled analysis of the Broadway and Brooklyn trials, investigators evaluated over 2,800 patients. The lipid effects were remarkable, as they have been in most of the studies of CETP inhibition. In this case, LDL-C was down nearly 40%, ApoB down 22%, Lp(a) down 32%, HDL-C up 140%. But again, this has been the story in a lot of these trials. The lab results always look good. But how about events? Overall, MACE wasn't significantly lower. But after 6 months, coronary events, death, MI, revascularization appeared to be reduced by more than half. Now, we published this study because it's intriguing. It's intriguing because it suggests the possibility that this CETP inhibitor could actually improve outcomes. But it led Neha Pagadapati and I to write an editor's note because we wanted to make sure that readers knew that although this was an important study, it needed more. This is a promising signal, but one that needed confirmation. We also have an editorial from Vera Bittner, who is even more cautious. She emphasized that the numbers are small, the effect was surprisingly large, and stroke was numerically higher in the obicetrapib group. So this is an example of us publishing something that is extending a hypothesis, is producing some intriguing data that maybe can help spark continuing research. Fortunately, the PREVAIL trial is now fully enrolled with more than 9,500 patients, and that will help give us the answer. Until then, this is a candidate, not a proven therapy, but one that we can feel that there's some anticipation that maybe this one is the breakthrough. We also in this issue have a trial perspective about the confidence trial. The trial tested simultaneous initiation of finerenone, a nonsteroidal mineralocorticoid receptor antagonist, and empagliflozin, an SGLT2 inhibitor, in people with diabetes and CKD. The result, albuminuria dropped by about 52% with the combination, compared with 30% with either drug alone. The effect was additive, and it happened fast, within 2 weeks. Safety was manageable and actually less hyperkalemia in the combination group than in the finerenone group alone. Now, it was only a 6-month phase 2 trial with albuminuria as the endpoint. So we can't assume clinical outcomes will mirror the surrogate. But the message is provocative. Starting therapies together rather than one at a time might accelerate cardio-kidney protection. So this one pairs nicely with the one with obicetrapib because in both cases, we're looking at studies that really weren't designed for outcomes, but are pushing us to believe that there may be good news ahead, but that needs to be demonstrated. In this one, the teaching point is thinking about shifting from sequential to simultaneous therapy in CKM disease. And you'll be seeing this. I mean, industry will probably be pushing this. What we're going to be waiting for is evidence that really strongly supports it. But there's precedent about thinking about combination therapy from the outset. So stay tuned here because there's going to be more to this story as more evidence becomes available. There's also an excellent state-of-the-art review on fibrinolysis. This is just a sweeping thing by Rashidi and Bigdelli. Benu Bigdelli is like a master at this. He's published a series of reviews, and I'm telling you that the illustrations are just breathtaking and informative. So fibrinolysis has been with us since streptokinase in the 1930s. The role narrowed in MI with the advent of PCI, but it's frontline in ischemic stroke and high-risk pulmonary embolism. Catheter-directed fibrinolysis is expanding in new areas, deep vein thrombosis, acute limb ischemia, even post-thrombectomy stroke care. This is the review you want to go to if you want to really understand the evolving agents, the dosing strategies, catheter-based techniques. It really is one of the best reviews I've read in a long time. One of the major points is that fibrinolysis is not a relic of the pre-PCI era. It's a dynamic field that remains central to modern care for thromboembolic disease. This issue has also information from across the JACC journals. From JACC Heart Failure, we present information on the vasoplegia syndrome after cardiac surgery, a poorly defined but highly morbid condition. The authors also call for clear definitions and targeted therapies. From JACC Cardiovascular Interventions, a consensus on atrioventricular conduction disturbances in transcatheter tricuspid valve procedures, and some crucial guidance about what to do as these therapies expand. From JACC Case Reports, 2 endocrine cases with cardiovascular consequences, thyrotoxicosis driving acute heart failure, and severe hypothyroidism masquerading as cardiogenic shock. These are quite interesting. I'm sure you're going to enjoy them. And one from JACC Asia, updates on drug-coated balloons as stent-sparing strategy, and new data on valvular heart disease epidemiology across Asia-Pacific region. So what did we learn this week? Well, I'll start with my editor's page. Good writing should not raise suspicion. AI can help, but accountability is non-negotiable. 2, nearly all cardiovascular disease is preceded by risk factors. The so-called Smurfless patient may be rare. We're going to need to see more research on this, but the study that we presented this week certainly suggests that if you look closely enough, you'll see that these traditional risk factors are almost ubiquitous in people who have events. For device infections, percutaneous debulking looks promising, but again, it was a really small group of patients, so we need more evidence. And prevention with leadless devices may be the real solution in the end. Next, CETP inhibition. Well, it doesn't look like it's dead. Obicetrapib offers a promising signal, but the PREVAIL trial will give us more information. And besides that, we're looking for many other studies that may support this direction, especially since we had negative studies in the class before. Next, upfront combination therapy in diabetes and CKD may protect faster and better than stepwise approach. But again, early data, we need outcomes. I hope you've enjoyed this issue. That's it for JACC this week. Until next time, stay curious.